Good afternoon, everyone. And thank you for attending this workshop, looking at the problem of depression certainly from a clinical perspective, but also from the perspective of our Christian faith. And I'm going to make an attempt here at integration. And I find that in a setting like this, it's best to leave a lot of time for conversation and questions. So my prepared remarks today are going to be relatively brief, about 20, 25 minutes, just introducing some basic themes on this topic. And then we will open things up for conversation. If you need a handout with the PowerPoint slides, just raise your hand and my friend Shane will come around and provide that for you. And I would ask you, and I'll remind you again later during the Q&A session, to please come down to one of these two microphones on either side and speak into the mic so that everyone in the auditorium can hear you, and also the folks that are listening and watching via our webcast can also have the benefit of hearing the question or the commentary. I believe that our Christian tradition has something important, indeed something indispensable, to offer to those who are suffering from depression. Now, certainly the medical and psychological sciences have taught us a great deal about depression, but the full story of this affliction is typically more complicated than sometimes we might assume. So the first point I want to make is that depression is really a multifaceted problem that cannot be fully accounted for by a sort of medical disease-based model alone. I was talking just to one of you before the session kind of about this theme. Biological factors, genetic factors are important, and they do play a role in predisposing individuals to respond to stress, let's say, by developing depressive symptoms. And a person with a strong family history may come into the world strongly predisposed to developing depression, even in ways that become relatively independent of their external circumstances. So those aspects are important. Biology is important, neurochemistry is important. But also important are, let's say, psychological factors, early life experiences, early attachment experiences with one's parents, for example. Interpersonal factors, past and current relationships, particularly the issue of loss in relationships. There are behavioral factors that I'll talk a little bit more about in a few minutes. And I would argue, and I think there's growing evidence for this, that there are social and cultural factors that play a role in increasing a person's risk for depression. I think now in American society, with social fragmentation, more and more social isolation, loneliness, the breakdown of the family, these sorts of things are collectively increasing our risk for certain kinds of problems like depression and anxiety. And I would argue, and I'll get to this in a few minutes, that there are moral and spiritual factors that are important both in understanding depression and in the process of recovery. So right at the outset, we need to recognize that to fully understand something like this, we need to look at it from several complementary perspectives, through several different lenses, if you will. Now, people that have not gone through a bout of serious depression themselves often misunderstand the nature of this illness. Right? They assume that it's more or less like what I've experienced when I hit a rough patch or have had a bad day. It's sort of a more prolonged, perhaps more intense period of sadness, but all of us have been sad from time to time. Perhaps there's even a danger in some cases of pathologizing or medicalizing something that is really just an ordinary sort of problem. But when we get to certainly more moderate or more severe forms of this illness, of depression, we see that it can be profoundly debilitating, that it can impair our mental and physical functioning in ways that go beyond just negative emotions. The famous novelist William Styron wrote a book on his own experience with depression. The title of the book is Darkness Visible, which actually it's a phrase that comes from Milton's poem Paradise Lost. This was Milton's description of hell in the poem. And I sort of alluded to this in the plenary this morning. One of the things that Styron sort of complains about in the book is the word depression, that it's sort of a pale word for something that can become a really terrible affliction. He prefers the older term melancholia, because depression sort of conjures up this idea of, a little dip in the road, or maybe an economic downturn, or something not so serious. I mentioned in my talk this morning the woman who told me, the patient who told me that she would pick her cancer, life-threatening cancer, over her depression because the depression caused her more intense suffering. There was a similar story. Just a couple of weeks ago, I was doing a radio interview, and the host, during the show, said that the depression that he suffered after the loss of his leg was actually worse than the physical ordeal or impairment of losing the limb itself. And I thought that was quite a striking statement on the nature of this illness. Back in 2003, in an address that he gave to folks on the theme of depression, Pope John Paul II said that depression is always a spiritual trial. Now, by saying this, he wasn't denying the medical or biological factors or nature of this illness. But he was recognizing something that I think is very important, and that's that depression has a tendency to affect our spiritual life, to sort of strike at our soul in ways that perhaps other medical problems do not. This is how he put it. He said, "This disease is often accompanied by an existential and spiritual crisis that leads to an inability to perceive the meaning of life." Right? Which is perhaps not the case with someone who's suffering from diabetes or hypertension. He goes on to stress how both mental health professionals like me and non-professionals, lay folks like many of you, motivated by Christian charity and compassion, can help those suffering from depression. The role, he says, of those who care for depressed persons and who do not have a specifically therapeutic task consists above all in helping them to rediscover their self-esteem, confidence in their own abilities, interest in the future, the desire to live. He goes on to say that it's important, therefore, to stretch out a hand to the sick, to make them perceive the tenderness of God, to integrate them into the community of faith and life in which they can feel accepted, understood, supported, respected, in a word, in which they can love and be loved. But what exactly is depression? How should we understand it? As I alluded to at the beginning, it's a complex condition that affects more than just a person's emotions. It can impair someone's cognition, their ability to think clearly. It tends to color our perceptions of the world and impair our ability to see things, literally to see things clearly. And it can impair our physical health and our bodily functioning in very profound ways. It disrupts, for example, the sleep-wake cycle, the normal circadian pattern, and people with depression oftentimes struggle with severe insomnia, or what we call hypersomnia. I've seen patients that are severely depressed that sleep 18 to 19 hours a day. Changes in appetite can become common, so people lose the ability to take in food, oftentimes with weight loss and the medical complications that go along with that, a diminished sexual appetite and interest, and someone's physical energy when they're in the thick of a depressive episode can be drained in the very same way that someone who's suffering from anemia or hypothyroidism or other medical problems, that really zap us of our strength and our energy. Depression can do all of these sorts of things, not just to our mind, but also to our body. Like the symptoms, the causes of depression are also complex, which is why, as I suggested at the outset, the medical model that characterizes depression as nothing but a chemical imbalance in the brain well, is true insofar as it goes, but it's also incomplete. Right? So those changes are there in the brain. They can be measured. They can be viewed on brain scans. You can go to Dr. Amon's workshop and hear about that later if you're interested. But I'll just give one example. Behavioral patterns can play a role in sustaining an episode of depression as well. One thing that happens when an individual is depressed, you can imagine, I feel like I've got very little gas left in the tank, right? My energy, my sense of vitality is almost totally gone. And there's a tendency then to want to conserve what little energy I have left. So rather than expend myself and get out of bed or get out of the house or engage in my usual routine of physical exercise or whatever, I'm just going to withdraw. And this can create a sort of behavioral, you could think of it as like an addiction to withdrawal or a phobia of energy expenditure. Well, unfortunately, that tendency tends to, rather than conserve energy, tends to drain the person further of their energy and vitality, and then tends to worsen depression, so they get into a sort of downward spiral. This does not mean that the person who is depressed because they're being lazy or because they don't want to exert themselves. It doesn't necessarily mean that they can just simply pull themselves up by their bootstraps by trying harder. But it does suggest that in addition to treating sort of the biological aspects, let's say with medications or other interventions, that there are behavioral interventions that can help people take small steps that are manageable, that can also assist them in recovering from depression. So medications and biological treatments have a role. Psychotherapy has a very important role in the treatment of most cases of depression. But I'm going to argue that these interventions should also be integrated with spiritual support and healthy spiritual practices. And about that, I'll say a little bit more in a few minutes and during the Q&A. I want to say a few words to help us begin distinguishing depression from what could be thought of as spiritual trials or primarily spiritual or moral problems. From the outside, someone who's depressed may appear to others to be lazy, perhaps falling into the deadly sin of sloth, or what the early church fathers called achadia. Some spiritual writers refer to this spiritual or moral state as a sort of spiritual lukewarmness, a kind of blah or whatever approach to the spiritual or moral life. I'm just not putting much effort into it. I'm getting used to sin. I'm abandoning my usual practices of prayer or church attendance, and so on. But I would like to suggest that someone who's dealing with something like this, or falling into a sort of spiritual laziness, should not be confused necessarily with the person who's suffering from depression. Right? Because the couch potato is not going to be experiencing the changes in sleep, appetite, energy, concentration, cognition, perception, all of these other things that I alluded to earlier that are key features of depression. I find in my own clinical work that patients or family members sometimes prematurely spiritualize what are actually more psychologically or biologically rooted problems. Right? I'm going through a spiritual dark night rather than I'm suffering from depression or anxiety or something else that might cause me to come to clinical attention or seek medical help. This phrase, the dark night of the soul, originated with the 16th century Spanish mystic and priest St. John of the Cross, who many of you have probably heard of, wrote a book called The Dark Night of the Soul. And oftentimes I find that, speaking rather loosely, without sort of more awareness of the theological or technical meanings of this term, Christians will sometimes refer to any spiritual trial as a dark night, dryness in prayer, or difficulties or doubts with faith, strong temptations, and so forth. Interpreting our problem in exclusively spiritual terms, without reference to these other perspectives that I mentioned, can sometimes lead people, if they fail to find relief in prayer or Bible reading or spiritual direction or the sacraments, it can lead them to become demoralized or to despair or to think, perhaps God has abandoned me because I'm trying to do everything right and yet I still don't feel better, or I'm still not able to function better. So it's helpful for pastors, for clinicians, for those who work and guide and direct people to try to help people distinguish what might be primarily a spiritual or moral problem from what might be primarily a psychological or medically related problem. When we're talking about the dark nights, for example, John of the Cross distinguished two. One he called the dark night of the senses, the other he called the dark night of the spirit. Both of these were a result of God's purifying the soul and actually increasing grace and God's own self-communication in the soul. These experiences of the dark nights purify the individual of excessive attachment to material things first, and even attachment to spiritual goods so that the person can more closely cling to God and God alone. And these experiences of purification might feel like darkness to the person. They may feel that God is not giving me the warmth or the comfort or the consolation that I used to feel in prayer, for example. So the person may lose sort of pleasure in the things of God, or lose the pleasure or the affective consolation that they used to feel in prayer. But unlike depression, someone going through a trial, a spiritual trial like this, is not going to have the profound loss of physical energy. They're not going to have the kind of mental slowing or the loss of appetite for food and so forth that we can see oftentimes in depression. They may have difficulty concentrating and focusing in their prayer, but usually they're able to do so and to function well mentally in other areas of their life. So I like to use the example of Mother Teresa to illustrate this. We know from the writings that were published after her death that she very likely, for long periods of her life, went through these kinds of spiritual dark nights and difficulties and interior trials. But even while she was going through this interiorly, on the outside, exteriorly, she was extraordinarily effective, right, in building her religious community, in her work of charity, and her ability to communicate the joy of the Lord to everyone that she met. So we can use, even if we're not a psychiatrist or professional, we can sometimes use our own sort of internal emotional radar to sense what another person might be going through. If I'm in the presence of a depressed person and I'm speaking with them, after a while I begin to feel drained and depressed and zapped, and sort of there's an emotional contagion aspect to this illness that tends to rub off on other people. Going back to the example of Mother Teresa, who I think was going through dark nights, but probably not what we would consider clinical depression. People that met her, that were around her, would always say the same thing. What they got from her was a sense of peace and renewed spiritual energy. A person going through a spiritual trial, like a dark night, also very likely will not be experiencing morbid thoughts of excessive, irrational, and unreasonable guilt or self-loathing. Feelings of utter worthlessness and suicidal thoughts are usually an indication that we're dealing with something like depression, something that should warrant, a clinical evaluation or clinical attention. Where can we find healing and comfort from depression if we're struggling with this ourselves or if we have a loved one? In addition to the standard recommendations of medication where that might be appropriate, or psychotherapy where that's indicated, what else can be done? I mentioned this morning the considerable body of scientific research, which continues to grow every year, that certain forms of prayer and meditation, like the ones that Father Luke Deisinger described in his talk, religious faith, participation in a religious community, especially in small groups where people feel very personally supported. Spiritual practices like cultivating the virtues of forgiveness and gratitude. All of these things can both reduce the risk of depression, of relapse for someone who's had a depressive episode, and can assist in recovery. And just to reiterate, this does not mean that religious faith inoculates a person against depression. It does not mean that depression is due to a person's lack of faith. But what it does suggest is that faith may have an important role in a person's healing. It's not the only thing that they need, but it is an indispensable and for many people a central piece of what they need, which should go hand in hand with these other psychological or medical interventions. I'll mention just one example. Healing from depression very often involves, first of all, restoring a person's sense of hope. This virtue of hope is so important for healing, and it's one of the things that oftentimes people with depression struggle with tremendously. A psychiatrist named Aaron Beck, who's famous in my field for developing something called cognitive therapy for depression, did a long-term prospective study of 1,400 suicidal patients. And he managed to follow these patients out for the next 10 years. And he was trying to determine which risk factors were most closely linked to suicide. So he followed them out, and he saw which ones ended up tragically dying by suicide and which ones ended up surviving. And could we find the key differences between these two groups, these two cohorts? And he looked at all the typical things that psychologists and physicians look at in these sorts of studies. What was the patient's diagnosis, the severity of their symptoms, the type of mental symptoms that they were struggling with, whether it was a mood disorder or psychotic disorder, medical problems that they had. Were they dealing with chronic physical pain, social factors, economic factors? Were they rich? Were they poor, married, unmarried, so on and so forth? Now, the results of his study surprised some behavioral scientists because it turned out that the one factor that was most predictive of suicide was not how sick a person was. It was not how severe their symptoms were. It was not how much money they had. The one factor that was most predictive of suicide was the person's sense of hopelessness. The patients who believed that their situation was intolerable and that the future held out no hope for them, these were the most likely candidates for suicide. Now, of course, there's no medical prescription or medical procedure for instilling hope. Hope is ultimately, for us Christians, found in the revelation of God's love and his promises to us. Now, we can have a natural sort of hope when things in our life clearly appear to be going well, and the outlook looks pretty bright. But when our situation in this life feels or appears hopeless, I think in those moments, the only hope that can ultimately sustain us is supernatural, is the theological virtue of hope, which is only infused by God's grace. Christianity can offer us hope in the midst of difficulties and pain. Christian faith suggests even that we can find redemptive value in and through our suffering when we're united to Christ's own suffering, at the same time, obviously, making use of all the resources available to try to alleviate our suffering. I'd like to conclude my prepared remarks with just a brief excerpt from the last chapter of my book, The Catholic Guide to Depression, which is on this theme of hope. And for those of you Christians who are not Catholic, I would just mention that the book does contain a few pages on distinctively Catholic practices, like the sacrament of confession, but 95% of what's in there would also certainly be applicable to Protestant evangelical Christians. So if you're interested, it is available out on the bookstore table on the patio. This is from the concluding chapter of the book. The virtue of hope can be cultivated in the context of our work, our family life, our leisure, in any honest human activity, and even mysteriously in our brokenness. We may sometimes wonder whether our efforts to be a better husband, a better employee, a better father or mother, friend or colleague are doing any good. Are these efforts worthwhile? Am I contributing anything meaningful to the world or to the church? St. Josemaria Escriva used the analogy of comparing us to the donkeys they used to harness to turn water wheels. Round and round the donkey would go, churning the pump that watered a distant field. This humble beast of burden, with its head down and its blinders on, labored in this routine work day after day. He never saw the flowers of the field that bloomed as a result of his efforts. But these flowers were no less real for being hidden from his sight. St. Paul put it this way: "For you have died, and your life is hidden with Christ in God." Our life, our work, the fruits of our labors, our suffering and our pain, all these things are hidden with Christ in God. And so we persevere, whatever the apparent results, whatever the outward successes and failures, because living and working for God is always fruitful. Christian hope is never individualistic. We hope not just for ourselves, but also for others. John Donne, who wrote the famous lines, "No man is an island sufficient unto himself," himself suffered serious bouts of depression and was tempted to despair. At times he contemplated suicide. But he understood, as these lines suggest, that to resist despair we cannot struggle alone. Because our life is hidden with Christ in God, we do not know the effects of even the smallest acts of love. A few years ago, a man in his 30s committed suicide by jumping off the Golden Gate Bridge. Afterwards, his psychiatrist went with a medical examiner to the man's apartment, where they found the dead man's diary. The last entry, written just hours before his death, said, "I'm going to walk to the bridge. If one person smiles at me along the way, I will not jump." We do not know all that we can be to another person. That smile, that small act of kindness, is hidden with Christ in God. Sometimes hope may seem like an unrealistic attitude, a luxury of those who do not realize how bad things are. A cheerful or optimistic outlook may seem ludicrous to the person suffering from depression. But such a person can, in fact, live in the objective joy, though at times perhaps unfelt, of a life of theological hope. Because the cheerfulness, the joy of a Christian is not a naive and easygoing optimism. It does not involve putting on blinders or ignoring the evil in the world. Our joy and peace are rooted in the virtue of hope, and our hope is grounded in the conviction that the ultimate victory belongs to Christ, a victory that he has already won on the cross. And our Lord says to us now what he said to his apostles: "Truly, truly, I say to you, you will weep and lament, but the world will rejoice. You will be sorrowful, but your sorrow will turn into joy." And he assures us, "In the world you will have tribulation, but take courage, for I have overcome the world." I want to thank you for your attention. And at this point, I would like to open things up for question and answer and conversation. Thank you.
Thank you.
If you have a question, go ahead and maybe just come down and you can line up here at the microphones.
Thank you very much for what you shared. As a marriage and family therapist, I've tried to use some different techniques with clients as opposed to traditional methods. For example, I've given as homework the reading of Choose Joy by Kay Warren.
Great book. I just finished reading it, actually. I'll tell Kay that. She'll appreciate that.
And I've seen some really good results with that, with some of my clients who are struggling with depression and anxiety. As you talked about some of the ways to recover from depression, you talk about prayer and meditation. How do we as clinicians integrate some more faith-based methods without our clients hearing, "You just need to pray more," or "You need to have more faith"?
Excellent question. So how can we integrate faith-based methods that are evidence-based without the client then getting the the wrong impression that what we're saying is you simply need to pray more, or you're suffering in this way because you're not praying enough, or you lack faith, or whatever. And I think that requires a lot of tact and delicacy, and it requires sometimes an explanation of the way in which we're going to approach this problem, looking at it from multiple different perspectives. So sometimes I like to give an overview of several different treatment recommendations, and then come back and review each one, one by one, and get into them in detail. So we're going to look at, okay, if a medication is appropriate, we're going to talk about that piece of it. If psychotherapy is appropriate, we're going to talk about what sort of psychotherapy, and then within psychotherapy, we're going to talk about the different ways in which we're going to approach this, looking at diet and exercise, and also then once you do the spiritual history, and certainly if you share the same faith background as a patient, that makes it all the more conducive to these sorts of interventions. So I would say present a broad spectrum of the way in which we're approaching this problem, so that the client or the patient sees that we're paying attention to a lot of different aspects of this, and I'm not just giving you sort of a quick Bible verse or a book recommendation and then asking you to run with it, or we're going to do 15 minutes of prayer or meditation a day, and that's going to do the trick. So I would say an overview of how you're going to approach this in lots of different ways, and then you can parse them out one by one, and that will help the person not get the impression that all I'm saying is, let's look at the spiritual aspect, or all I'm saying is, take this pill and then you're going to feel better. It also requires sometimes educating people who walk into the office already believing that I'm going to get a simple answer to this question. So explaining that the answer is going to be sort of complicated because the affliction itself is complex. That kind of educational work before you even get into the business of what am I going to recommend to you? How do we understand what's going on with you from lots of different perspectives, so that you recognize it's not simple. It's not just the chemical imbalance, or it's not just that I'm having a spiritual problem. It's something very complex, and we need to respect all those different aspects of it. And a lot of times you kind of have to prepare the ground first before you launch into what are we going to do about it. Great question. Thank you.
You referred to a term called clinical depression. So I guess there's an ordinary depression versus a clinical depression. And what would you use to define that? Yeah. And then what percentage of the general population would you say suffers from bouts of depression? Yeah. I'm a small groups pastor, and in different small groups, it's almost like 2/3 of the people have suffered from different forms of depression at some time. And what percentage of those would need medication or psychotherapy or whatever?
Boy, you had to ask that question, didn't you? First of all, there's no good consensus on this. I mean, psychiatrists can and do argue endlessly about where do we set this bar, because obviously these things exist on a spectrum, and there is a place, there is a gray area where ordinary sadness or grief or bereavement can then shade into perhaps something more serious. And how many symptoms do you need? How severe does it have to be? How long does it have to last? I don't have a good, clean answer for you on that, except to say that, I criticized Sigmund Freud this morning, but he was right about one thing, that because of original sin, all of us are sick to some degree or another. No one is perfectly mentally healthy, aside from our Lord, and perhaps some of the saints who have gotten closer to that ideal than most of us. But even then, lots of the saints suffered from mental disorders too. So, but some quick and dirty criteria that I think can flag you to suggest that maybe this is something that warrants more attention, clinical attention. Certainly suicidal thinking. Right? So, but depression is an illness that can be literally can be fatal. The suicide rates for moderate to severe depression are tragically high. And I don't think it's the case that we can prevent all suicides, sadly enough. But I think we can do a lot to reduce the risk of suicide. So if someone is struggling with suicidal thoughts, then intervening there, that can be life-saving. Psychiatrists usually fall back on this concept of functioning, to designate what should count as a mental disorder that should require clinical attention versus ordinary, difficult human life experience. So if a person is getting to the point where they're not able to do ordinary routine activities that used to come rather naturally or easily, whether it's work or if they're a student, it's, they're struggling now in school in ways that are hard to account for, those can be signs that ordinary sadness or the blues might be shading into the realm of something that may require professional attention or more dedicated clinical treatment. But with all that said, it's a tough question to answer because these things are existing on a spectrum. And I think we could probably argue endlessly, if you set the bar here, then we're pathologizing normal experience and we're turning everyone into someone who needs medicine. But if you set the bar too high, perhaps we're missing some people that are at high risk for negative outcomes. We know, aside from suicide, we know that people that struggle with depression also have worse outcomes with other medical problems, right? So they're at higher risk for heart attack, higher risk for stroke, higher risk for relapse on certain medical issues. So we don't want to miss those folks either and avoid offering them help for their depression when, going untreated, these things can have serious medical consequences for them. The other thing I would say, too, is that it can be helpful just to go talk to someone, even if you're not going to start in on a course of psychotherapy or a course of medication, just so you can learn more about the symptoms. Okay, I'm doing okay now, and I'm still struggling, but I'm managing all right. But if I get to the point where I'm experiencing this or this or this, I know it's time then to come in and maybe seek clinical attention again. So, not everyone that comes to me for an evaluation is someone who necessarily requires treatment. Sometimes they just want the peace of mind of having someone, from the outside look at their situation and give them some advice or some things to look out for in the future.
Yeah, I was wondering if you could tell us, as pastors, we counsel people who find that they do go to their doctor or psychiatrist, need meds, but yet they feel anxious about the idea of taking them.
Sure.
So how can we help coach them and remove some of that anxiety? And is it true that there is no med that takes away just the bad feelings? They're also going to lose some of the highs and the joys as well. And so is it going to reduce them into a more of a mid-range area to live for a while? And how can we help them through that?
Right. Good question. So the stigma against taking medications, a lot of folks that would have no problem taking a medication for another medical problem, like diabetes or high blood pressure or cholesterol issues, would then hesitate to start an antidepressant if it was warranted. The whole issue of risks and benefits of medications is complicated. Some patients do experience a certain kind of emotional numbing on antidepressants, and that can be uncomfortable. That may mean they need to switch to a different medication or try something else. People that have bipolar tendencies, and I believe there's another workshop today on bipolar, oftentimes like the highs, like the manias, at least when they're mild, and so getting them on a mood stabilizer might take away some of that energy that they previously enjoyed. So it can be difficult. It can be complicated for some people. But I would encourage them, first of all, to recognize that medications are not the only answer to this problem, but they may be a very important piece of it, and that they can work hand in hand with other interventions. And look, God gave us everything in nature, and He gave us an intellect to figure out the brain and how the brain works, and the body and how the body works, and to invent, anesthesia so that surgeries become easier and more comfortable. And I would argue to invent antidepressants, which can be life-saving. There's some important research that has been done in the last few years, because there was controversy about this for a while, but now the evidence is pretty clear that antidepressants do reduce the risk of suicide and in the aggregate can save lives. Are they overprescribed in some circumstances? Are they used sort of cosmetically in some circumstances where people may not need them. Yes, I think that can happen. That can certainly be possible. Unfortunately, medicine and primary care especially is going to shorter and shorter doctor visits with, more and more prescriptions going out the door. And so there is that problem, and there is perhaps that tendency to medicalize too many things. But at the same time, we don't want to throw out the baby with the bathwater. We want to recognize the value and the role of these things. And I think as a pastor or a small group leader or someone that is assisting from a pastoral perspective, you actually have more credibility, and probably with certain individuals, you're going to be more persuasive. Of course, the doctor's going to tell me that I need to take a pill, but then when my pastor also says, no, it's okay to do this, there's nothing unchristian about this, there's nothing in the Bible that says that you ought not do this, that can be just the thing that they need to sort of remove the stigma, because they expect to hear it from me. They may not expect to hear it from you. So I think you've got a very, very important role there in encouraging them and telling them, no, look, this is okay. This is not something that you need to be ashamed of. And in terms of the exact risks and benefits of the medication, well, that's a conversation that you need to have with your doctor. And if you feel like he's shuffling you out the door without giving you the answers, go find someone else who's going to sit down with you and give you the time that you need to really understand what's going on and why he or she is making the recommendation that they're making.
Hi, my name is Sparky McGraw, and I've been a member of Saddleback for 22 years. And I decided this year for my transformation, I'm going to be writing a book about my life growing up with learning disabilities. Wonderful. And also this last almost 10 years off and on, I have suffered from depression, anxiety, panic attacks, not sleeping for nights on end, and just going from doctor to doctor trying to get all this diagnosis. And finally, it was because I was going through hormonal stuff, so that's been corrected. So now all my depression is basically gone. And then I also discovered I have Asperger's syndrome, which I always have a certain amount of social anxiety.
Right.
And I also have a problem in June when the fog comes in. I don't know. But that's what I'm going to be doing. And
Wonderful.
I'm working with the doctors at Chapman University in a likely place that I'm going to be doing my research and stuff.
Wonderful. I think it's so important. I think it's so important that folks do what you're doing, which is to tell their stories, right? You're going to be writing about your experiences, and that's going to reach people that I'm not going to be able to reach, or that maybe the pastor at the church here is not going to be able to reach, because you know what it's like to have gone through these particular things, and you can connect with others that have struggled with similar questions and similar things as well in their life. So I want to thank you for your willingness to come up and share your story given the social anxiety. And I would encourage you, and I'm going to pray for you and for your writing. Thank you.
My name's Nicole. A few years ago, I was diagnosed with bipolar type 2 disorder. And so I have experienced a lot of the depression swings, and
Right.
Praise God, I'm on good medicine, getting good care now, and I'm really thankful for that. But my question is, as we do go through times of depression, and we've learned to, or at least I think, put one foot in front of the other, and eat 3 meals a day, get good sleep as we can, exercise, those sorts of things. I sometimes wonder what that looks like spiritually for us, to put one foot in front of the other, and practically just your recommendations for that, or your opinion on what that looks like.
Sure. Thank you also for sharing your story. In my own Catholic tradition, there's there's a form of spirituality known as spiritual childhood, and various modern saints like Saint Therese of Lisieux, Saint Josemaria, who I quoted in the talk, have really written about and encouraged this idea of spiritual childhood, of seeing ourselves as not just a child of God, but a small child of God. You know, a toddler taking her first steps. And when we're struggling with medical problems, when we're struggling with mental health problems, sometimes all we can do is take little steps. And in our spiritual life, sometimes all we can do is take little steps. So a trusting abandonment to God, recognizing that right now, when I'm going through this depression, prayer or my usual devotions have become very, very difficult. I try to read the Bible, and my mind really can't take it in, or I can't focus on it. Well, at that point, maybe I have to recognize that what I'm capable of is reciting the Lord's Prayer slowly, over and over. Or the Jesus prayer that Father Luke mentioned this morning, Lord Jesus, Son of God, have mercy upon me. That may be a more profound act of faith than powering through 6 books of the Old Testament, or whatever you had on your spiritual game plan. And so I think that idea of spiritual childhood, of divine filiation, that I'm a child of God, that God is my loving Father, and seeing myself as little and needing then to lean more and more on my Heavenly Father, is very important for anyone who's sick and ill and struggling in that way, rather than I'm going to be spiritually strong and powerful and I'm going to spiritually bench press 400 pounds, which that is probably not what God is asking of you, especially during those periods of your life. So, thank you.
On the handout that you gave today that showed the slides, there was a slide there that you didn't really talk very much about. You're talking about treatments that were effective for people. You said something about groups on there. Now, I know that there are psychotherapy groups where people can go, but what about a group that would be led by a lay caregiver? Is that effective, and what does that look like?
Yeah. No, great question. So lots of groups out there, lots of support groups, lots of more professionally led groups, but the research on group psychotherapy shows that groups that are led by a professional therapist or clinician obviously can be effective, and there's lots of different models for those. But lay-led groups or patient-led groups, if they're well-structured and if they have some appropriate framework, can be extremely effective, oftentimes just as effective as other groups. And there are some models out there for that as well. Celebrate Recovery Here is one model. 12-step programs. Alcoholics Anonymous is another model of non-professionals helping other folks that are struggling with the same problem. So certainly for things like depression and anxiety, I think there's a huge role and a huge place for this. And I think churches can be a natural place where grassroots efforts like this can grow up. The groups need some norms. They need some sort of rules of engagement and confidentiality and other things to make them work well and to keep them sort of on track. So it's important to have some structure, but you don't need to be a psychologist or a psychiatrist to do these sorts of things.
Is there good curriculum out there that can be used?
That's, one of the things that we're doing after this conference is we're going to use the website for the conference as a sort of central clearinghouse for good models out there of this kind of thing. So I don't have all of them at my fingertips, right, but our planning committee is working on gathering some of those resources so that if you got on and you registered for the conference, we've got your contact information. We're not going to spam you with a bunch of stuff, but we will try to send out helpful resources from time to time. So please stay tuned and stay in touch with us.
Thank you.
Hi. As somebody who's struggled with major depression for many years, as I've gotten older in my mid-50s now, I'm seeing a correlation with hormones, hypothyroidism, and it's kind of morphed into what my psychiatrist told me last week is like a mixed state. And right. I'm not real clear on how all that works together.
Neither are we. And when I figure out the connections between hormones and mood, and I win the Nobel Prize, and I'm getting that at Stockholm, then I'll remember the question that I wasn't able to answer. There's been a lot of research, especially with postpartum depression, right? Because we know that there are huge hormonal shifts right after a woman gives birth, and we've known for a long time that that is a very vulnerable period for developing depression or developing manic or psychotic episodes if you have a predisposition to that as well. And they've looked at estrogen, they've looked at progesterone, they've looked at the absolute numbers of those hormones, they've looked at the changes, the shifts, and we haven't sorted it out yet. We don't, whatever the answer is, it's not very chemically or medically straightforward. So what we have right now are correlations. So we know menopause and, just after delivery is a vulnerable period for individuals. We know that many women experience premenstrual dysphoria, before they have their monthly period. But exactly what role the hormones play there and how that all works, we're still, to be honest, we're still trying to figure that out, and we actually have more questions than answers. There has been some research on hormone replacement therapy and other attempts to intervene there, and for some women that turns out to be helpful with depression at that stage of their life. But the evidence is not real solid, and so hormone replacement therapy and other hormonal interventions are not as widely used right now as antidepressant medications because they don't appear to be as effective, or at least we haven't figured out the right approach there and the right mix of hormones to fix the problem.
And how would you define a mixed mood state?
Well, I'm not sure how your psychiatrist is using that term.
Related to bipolar 2 and depression.
Yeah, okay, well, in bipolar disorder, I actually don't like the word bipolar disorder because it suggests that you're either at one end of the spectrum or the other. Either you're manic or you're depressed. Bipolar used to be called manic depressive illness, and people thought that name was too stigmatizing, so they changed it to bipolar. But to me, manic depression is a more accurate name for the illness because while it's possible that you could be in a purely manic state or in a purely depressed state, it's oftentimes the case that you have symptoms of both at the same time. So a mixed episode or a mixed state is basically having symptoms of mania and depression at the same time, a sort of agitated depression, if you will. And it can be extremely unpleasant and one of the worst aspects of that illness. So, and it can be hard to diagnose and recognize sometimes too, because it doesn't look like the classic textbook depression or the classic textbook mania. What you've got is a mixture of the two at the same time. Yeah.
Yes. I have a brother and another relative that has OCD. At least that's what they tell me anyway. And I'm not that familiar with the condition, but my brother, who's very close to me, he's extremely brilliant. He's an engineer for aerospace, and he was seeing a therapist for a while and taking medications, but then he had this reaction to the medication, so he's cut that off. And in my last discussion with him, I tried to touch bases with him every couple of weeks. He's no longer going to his therapist, and he seems to me to be sort of maybe withdrawing and trying to fix this himself.
Right.
Feeling he's getting books, and he recognizes that he has this illness, and he can fix it. And I'm concerned because I don't want to see anything happen to him, and we've heard the discussions here about how connectedness is so important.
Right.
And what can I do as a family member to encourage him to get help, and what should be my strategy?
Yeah, well, I think you're right to be a little worried because if he's just sort of diving into his books and trying to think his way out of this, his thinking is one of the things that's getting him stuck, right? And people with OCD, their recovery can become stuck in the obsessional rut as well. So I think your instinct is correct, that he needs to reach out to other people in order to get help for the problem. if medications didn't work or he's not amenable to medications, there are lots of other treatment approaches. Cognitive and behavioral therapy are effective for OCD. Mindfulness-based cognitive therapy, something called acceptance and commitment therapy, can be helpful for OCD. So OCD involves intrusive thoughts that are excessive or irrational, that cause anxiety. I had a patient once who, every time he went over a speed bump, would have the intrusive thought, what if that wasn't a speed bump? What if I just ran over a dead body? And unlike a person who's delusional, he recognized that thought's a little crazy. It doesn't make sense. I know it was a speed bump, but the obsession is an obsession because he can't shake that thought. People that have these obsessions tend to engage in compulsive rituals to try to undo or diminish the anxiety that the thoughts cause. So that's the compulsion part of OCD. The obsessions are the thoughts, the compulsions are the behaviors. This particular individual, his behavior was to check, to drive around the block again, make sure, okay, it was a speed, he would end up going around and around and around because the obsessions would continue. Usually when you get into the compulsive ritual, whether it's hand washing or mental exercises like counting backwards or whatever it is, it might, for the moment, take away the anxiety, but it ends up over the long term only amplifying the obsession, and the person tends to get into this cycle. So breaking the behavioral cycle of the compulsive rituals is usually the first step, and that often requires an external coach, if you will, a therapist helping him to set reasonable goals and strategies and recognize when he's falling into this pattern, because a lot of times this becomes so habitual that people are not even aware. Oh, that is another obsession. All right, that is another compulsive behavior. So what can you do? Continue to try to understand and listen to him and be very patient. People with OCD tend to be overly inclusive in their speech and can go on and on and on, and it can be a little bit tiring to listen to them after a while. So just exercising, that Christian virtue of patience. And then perhaps encouraging him that, okay, well, if you're worried about medications, let's at least look at other options. Maybe there's a therapist who can help you. Maybe encourage him to watch some of the DVDs from the conference of some of the talks that might speak more directly to his circumstance. If he just gets lost in his books, I think, unfortunately, he may not find too much relief there. And prayer, we can't underestimate the power of praying for a loved one.
Thanks.
Do we have to cut it off? Okay. I'm sorry if we didn't have time to get to your questions. Thank you all again for coming today. I hope you found it helpful.